Good afternoon and welcome. My name is Cherie Mitchell, Director of APA HIV/AIDS programs. On behalf of the American Psychological Association's Health Disparities Office, I would like to welcome you to the webinar, Should We Still Care? The Continuing Need for Behavioral Interventions to Reduce Health Disparities in HIV/AIDS. We are fortunate to have two leading experts in the field, Dr. Monica Ulibarri and Dr. Eugene Farber, who will discuss this important topic. If you have questions, please type them into the chat box and we will address them at the end of the presentation as time allows. Also, the slides will be available on our website. The objectives for the webinar are as follows. We'll just talk about the current epidemiology and data regarding HIV disparities, discuss psychological, social, behavioral, environmental, cultural, and structural factors that impact marginalized populations at risk, discuss evidence-based prevention and treatment to include behavioral and biomedical interventions, and finally discuss the unique role of behavioral health in development and optimization of effective culturally appropriate approaches and the integration in medical care and the health service delivery. Our first part of a webinar will focus on HIV/AIDS disparities in the United States, presented by Dr. Monica Ulibarri. Dr. Monica Ulibarri is an associate professor in the California School of Professional Psychology and Clinical Psychology PhD program at Alliant International University, San Diego. Dr. Ulibarri also holds an appointment as voluntary associate clinical professor in the Department of Psychiatry at the University of California, San Diego. Dr. Ulibarri's research focuses on HIV prevention with marginalized populations, such as female sex workers, people who inject drugs, drug-involved couples, and commercially sexually exploited youth along the Mexico-US border, with an emphasis on how gender-based violence, mental health, and substance use intersect with HIV risk behaviors. Dr. Ulibarri is the current chair of the APA Committee on Psychology and AIDS. Dr. Ulibarri.
Thank you. I'm going to begin today discussing about HIV/AIDS disparities in the United States. Next slide. I'd like to start with some definitions. So first of all, what is HIV? HIV is a virus that attacks the body's immune system. It can spread by certain body fluids such as blood and semen. And untreated HIV reduces the number of CD4 cells in the body. CD4 cells are part of the immune system and are attacked and destroyed by the HIV virus. This makes it harder for the body's immune system to fight off infections and some other diseases. These result in what are called opportunistic infections, or sometimes cancers, and they take advantage of the weakened immune system. Which can indicate that the person has AIDS. I provided a link here for you to the CDC's HIV 101 infographic, and it's available in English and Spanish. If you're doing outreach, you may want to print out some of these infographics for your organization. They're really helpful. Next slide. So some definitions of HIV and AIDS. What's the difference? HIV refers to a diagnosis of HIV infection regardless of the stage of the disease at diagnosis. So there are several stages, 0 through 3. HIV infection stage 3, which is also known as AIDS, is the most severe level of HIV infection. And persons with diagnosed HIV whose infection was classified or has ever been classified as stage 3 during a given year are given the diagnosis of AIDS. Next slide. I'd also like to make sure that everyone understands the difference between prevalence and incidence. So HIV prevalence is the number of persons living with HIV at a given time, regardless of the time of infection and whether or not they are aware of the infection. So this can be thought of as like the total number of cases at a particular given time. Incidence is the estimated number of persons newly infected with HIV during a specified time. So this is more new diagnoses or cases, and you usually see the time period specified as 1 year or past year. Next slide. HIV/AIDS surveillance or data about how many people have HIV and AIDS is available from the Centers for Disease Control and Prevention. They update data about every 2 to 3 years. The most recent report was published in November 2017, and I've provided the link for you to go and look at all of the data. There are many good slide sets, graphs, and tables with information on HIV and AIDS by demographic variables, mode of transmission, the region of the United States. The data that I'm going to show you in the subsequent slides comes from this most recent report. And I'm going to highlight many of the HIV disparities that exist in the US, but you can look at the data in many different ways and what's most interesting to you when you look at, when you go to that website. Next slide. All right, lastly for definitions, I want to go over what is considered an epidemic. UNAIDS definition of generalized epidemic is one in which the HIV rate among the general population is greater than 1%. To give you an example, the US maintains an HIV rate of less than 1%. So we are not considered to have a generalized epidemic in the US population as a whole. However, there are areas and communities in the United States where the rate of HIV is concentrated and therefore may indicate an epidemic in that region or community. So we're going to see some maps of the concentration of HIV in the United States. Next slide. This slide represents rates of adults and adolescents living with the diagnosis of HIV infection at the end of 2015 in the United States and 6 dependent areas. Areas with the highest rates of persons living with diagnosed HIV infection at the end of 2015 were the District of Columbia, New York, Maryland, the US Virgin Islands, and Florida. And you can see the states and the areas shaded darkest purple represent the highest concentration of HIV infection. So very clearly from this map, you can see somewhat bi-coastal hot areas and the southern United States. Next slide. I wanted to say a bit about HIV/AIDS in rural communities because you can see from the previous slide that many states in the many southern states in the United States are affected by HIV and AIDS. These barriers can affect communities across the board, but pose particular problems in rural areas in particular and may create these disparities that you're seeing in the map. For example, stigma and lack of privacy. In small communities where everyone knows everyone, people may feel particularly worried about stigma and therefore not go in for HIV testing and not want their status known or to be known that they are receiving treatment. Lack of awareness can be an issue in that sometimes people are not or do not think that HIV may be an issue that affects their community, and they may not realize that their area is actually an area in which HIV is occurring. There may be limited access to providers and services, or the services that do exist may be very far, maybe even hundreds of miles away or in the next closest urban area, which may be difficult for some people to access. And this also in turn creates cost. It may be expensive to get to where you need to receive the care, and the care itself, if you are not insured, may be very expensive to obtain treatment. Next slide. Okay, we're going to look at some of the surveillance data by sex, age, and mode of transmission. Next slide. On this slide, you will see that HIV is more prevalent among males compared to females. So this is showing the diagnoses of HIV infection among adolescents and adults and adolescents by sex in the United States. So you can see males have a much higher rate of HIV infection than do women. Next slide. This slide presents the rates of diagnosis of HIV infection by age group among adults and adolescents in the United States from 2010 through 2015. And you can see from these different colored lines, for example, persons aged 25 to 34 years, which is the top yellow line, accounted for the highest rates of diagnoses of HIV infection each year across the board. And what is concerning here you can see is that it's actually rising and going higher. Whereas persons aged 55 and older accounted for the lowest rates of diagnosis of HIV each year. And you can kind of see the trends in some of the other lines. For example, 35 to 44 years has been decreasing pretty steadily, but 13 to 24 years is increasing. All right, next slide. This slide presents the percentage of distribution of adults and adolescents with diagnosed HIV infection from 2010 through 2015 by transmission category for the United States and 6 dependent areas. So you can see for here that male-to-male sexual contact is the most prevalent mode of HIV transmission, followed by heterosexual contact. And the lower two lines, injection drug use and male-to-male sexual contact and IDU, are, you can see, less than 10% of the way in which people have become HIV infected among those who are diagnosed with HIV. Next slide. In this slide, you can see that among men, this shows transmission by males and females. And you can see that among men, the mode of transmission is primarily male-to-male sexual contact. So that's that green bar at the top, what says 71%. So that's 71% of men who are diagnosed with HIV, what the mode of infection was male-to-male sexual contact. Whereas for women, you can see with the purple bar that says 75%, the mode of transmission that is most prevalent is through heterosexual contact, followed by injection drug use. And I think what's also interesting in this slide is that you can see that for women, injection drug use is more prevalent form of modality of HIV infection compared to men, so 22% versus 11% in men. Next slide. This slide is specifically about AIDS or stage 3 HIV. And what's important to note here is how the epidemic has changed over the years. So you can see these big spikes from like 1989 to the late 1990s. And then with it, you can almost see where the introduction of biomedical treatments and advancements takes place because there is a sharp decline of HIV AIDS, which would indicate that people who are infected with HIV are not transitioning to more severe levels. But I also want to point out, if you look at the purple line of heterosexual contact, that actually increases over time and crosses injection drug use around the year 2000. And we're seeing now at around 2015 that for the majority of all of these modalities, they're declining. All right, next slide. Next, I will show you some data by race and ethnicity. Next slide. This shows the diagnoses of HIV infection among adults and adolescents by race and ethnicity from 2010 to 2015. African Americans and Black Americans accounted for the largest percentage of diagnosis of HIV infections each year in the United States and 6 dependent areas. So you can see that represented in that purple line, which is higher than all of the other colored lines. Next is the yellow line of white Americans and that aqua colored, green colored line of Hispanics and Latinos. The proportion of diagnoses among Hispanics and Latinos is now nearly the same as the proportion among whites. And I also wanted to explain that little smaller pop-out graph on the top. That has multiple mixed races, Asian Americans, American Indians, and Alaska Natives and Native Hawaiians and other Pacific Islanders. They were all less than 4%, which wouldn't have shown on the larger graph. So they made a pop-out graph to show the rates here. What you can see there is you can then see that among Asian Americans, it's actually increasing. Next slide. This slide presents the comparison of racial and ethnic distribution among persons with HIV infection diagnosed in 2016 and the general population. Here is where you can really see the disproportionate rates of HIV among Black and African Americans. So for example, if you look at their bars, they are 12% of the US population, but represent 44% of those infected with HIV. As opposed to white Americans, if you see there, they are 61% of the US population, but represent 26% of those who are infected with HIV. And you can see for Hispanic and Latinos, there's also a disparity. Next slide. This slide shows the proportion, the comparison of racial and ethnic distribution among males specifically with HIV infection compared to the general male population. So again, you can see the disparity. It's going to, for African American and Black men are 12% of the US population, but represent 40% of those infected by HIV. And you can see the bars for white Americans and Latinos. So again, here the Hispanic and Latino population is disproportionately represented among those with HIV. Next slide. This slide shows that information among women, and I think here you really see the alarmingly high rate of HIV and AIDS among African American and Black women. That really highlights the disparity. So they are 13% of the US population, but represent 61% of those who are infected with HIV. And you can see, interestingly here, for Hispanic and Latino women, it is roughly the same. They both 16% of the US population and 16% of those with HIV infection. Next slide. These next slides are going to show you HIV stage 3 or AIDS specific information. Next slide. This slide I think is interesting because it's indicative of the access to care and treatment. So these are adults and adolescents living with diagnosed HIV infection ever classified as stage 3 or AIDS. So again, you are seeing the disparities among African Americans and Black Americans and their progression of HIV into stage 3 AIDS. And actually, you can see among all ethnicities that it has been steadily increasing over time. And in the smaller pop-up graph, it is a very steep incline or increase for Asian Americans. Next slide. This slide presents the rates of death for persons with diagnosed HIV infection by race and ethnicity from 2010 through 2015 in the United States. From 2010 through 2015, the rates of deaths for American Indians and Alaska Natives, Asians, Blacks, African Americans, and Hispanics and Latinos decreased. And the rates of deaths for whites and persons of multiple races remain stable. In 2015, the highest rate of deaths was for Blacks and African Americans. So again, still seeing disproportionate, this is indicative of disproportionate access to treatment and care. Next slide. I also wanted to include some information about pediatric HIV surveillance. And again, you will see the disparities among African American and Black children. Next slide. So this slide shows the diagnoses of HIV infection among children aged 13 or younger by race and ethnicity. And you can see from the purple line, which is higher than all of the other races, that African American and Black children represent the have the highest rates of HIV infection among children in the U.S. Next slide. And this again highlights the HIV/AIDS disparities among the African American and Black population by showing that African American and Black children are 14% of the US population, but represent 64% of HIV cases among children in the US. All right, next slide. So there are various prevention models for HIV infection, and they include behavioral interventions, such as increasing condom use, prevention with people who are already diagnosed with HIV, preventing transmissions with medications, so biomedical treatments, harm reduction strategies such as condom distribution programs and safer injection of drugs, and social marketing campaigns for high-risk groups. My colleague, Dr. Farber, is going to speak about many of these in more depth in the next part of our webinar. Next slide.
Thank you, Dr. Ulibarri. That was a very interesting, informative presentation. The second part of our webinar will focus on the roles of behavioral health in optimizing HIV prevention and treatment, presented by Dr. Eugene Farber. Dr. Eugene Farber is Professor and Director of Psychology Internship Training in the Emory University School of Medicine, Department of Psychiatry and Behavioral Sciences. He also serves as Director of Behavioral Health Services at the Grady Health System Ponce de Leon Center, where he oversees an interdisciplinary behavioral health program set within one of the largest and most comprehensive academically affiliated HIV primary care centers in this country. Dr. Farber's scholarly work includes research on resilience factors influencing HIV-related psychological adaptation, clinical outcomes of HIV behavioral health services, adherence and retention in HIV care, and pathways through which contemplative methods may influence stress and immune functioning in persons living with HIV. Dr. Farber.
Well, thank you, Cherie, and I'm glad to be on the webinar today. And thank you, Dr. Ulibarri, for a wonderful introduction to the epidemiology of HIV and some of the basic concepts in HIV treatment. What's clear from that presentation is that there are some very significant health disparities associated with HIV, where it hits certain communities particularly hard, particularly Black African American communities, and also to a large extent Latinx communities. What I'm going to do is talk a little bit about what we as behavioral health professionals can do to help reduce some of these disparities, and particularly how behavioral health can help to optimize our advances in biomedical treatment of HIV as well as HIV prevention. Next slide, please. So for the first roughly 30 years of the HIV epidemic, really the main prevention tools we had were behavioral. And the highlighted ones are here on this slide. The first one is condom use and applying psychological knowledge, largely from social psychological models, to help develop knowledge, skills, and motivation to use condoms as prevention methods. We also heavily emphasized educating people about safer sex practices and helping them to develop self-efficacy and advocating for themselves around safer sex practices, helping people to develop communication skills, and in the context of both self-efficacy and communication, promote healthy sexual relationships that helped people to prevent their risk for HIV infection. In addition, we focused our behavioral intervention efforts on harm reduction, particularly substance use risk reduction interventions, needle and syringe exchange, and then, of course, behavioral health specialists were on the front lines of substance use treatment. These behavioral HIV prevention strategies remain extremely important, but around 2010 or so, and we'll go to the next slide, we entered a new era of biomedical HIV prevention strategies. Now, there were some around before 2010, but really this was the year that we started to get some new data from trials that showed that if we gave HIV medications, antiretroviral medications, or ART, to people who were not HIV positive but at high risk for contracting HIV, we could dramatically reduce and in effect eliminate their contraction of HIV. So this came to be known as pre-exposure prophylaxis, or PrEP for short. And PrEP it targets people who are at high risk for HIV. So if they live in a community that might be called an HIV hotspot because there are high rates of infection in that particular community, so there is an epidemic in particular communities, then those communities might be targeted for PrEP. It involves daily antiretroviral medication, and the particular ART that has been used and tested is Truvada, although there are some additional ones coming out. And this is a combination of two different HIV agents, antiretroviral agents. It's highly effective when adherent. It reduces the risk of infection almost to zero. But the barrier methods are still recommended because A, it provides additional protection, and B, it prevents infection with other sexually transmitted infections. A second area that's been around a little longer than PrEP is post-exposure prophylaxis, or PEP. And this is administered when someone is exposed to HIV, only it's instead of being given beforehand like PrEP, it's given afterwards. So this is something that's been used with healthcare workers who come into contact with bloodborne pathogens, but also people who may have been in sexual contact with someone who was known to be living with HIV, and they could be given PEP if it's given quickly enough. It involves giving a 28-day course of ART, and it must be started as soon as possible following the exposure, but no later than within 72 hours in order to help prevent a full-blown HIV infection. Next slide, please. An additional biomedical prevention strategy that I want to mention, and this is associated with one of the great early success stories in the history of HIV, and that is efforts to prevent mother-to-child HIV transmission. That's called vertical transmission of HIV. And that requires early HIV detection and ART administration in pregnancy and childbirth, and then ART administration to the infant for 4 to 6 weeks following birth. and also making sure that the mother feeds with baby formula and not breast milk, because breast milk can transmit HIV after birth. The reason I mention this to be one of the great success stories is because when we use these methods, transmissions to infants becomes zero. So there really is no reason that any infant should be born with HIV from a medical perspective, but obviously there are social factors that prevent access, that prevent people from knowing that they're infected. So they may be going through a pregnancy and not even know that they have HIV. But from a medical standpoint, there's no reason that there is that a child should be born with HIV. And it is when these methods of preventing vertical transmission came on the scene, there were dramatic drops so that in children born with HIV. So that, for instance, in the program where I work, we have a pediatrics clinic, but very, very few of our clients here are infants or small children living with HIV. They tend to be more teenagers and young adults who were infected through sexual contact or drug use. Next slide, please. So the larger sort of biomedical intervention is what we call HIV treatment as prevention. And again, around the same time that the initial research was coming out about PrEP, around 2010, 2011, there started to be studies that suggested that people who were what we call virally suppressed, which means that the amount of HIV in their blood is reduced to undetectable levels, and that's defined as less than 200 HIV copies per milliliter of blood. That when people achieve this viral suppression, they do not transmit the virus. And in fact, the research trials on this have been very impressive, and essentially we say it's a very low risk, but the research trials have been essentially 100%. So that if somebody's virally suppressed, it seems that they cannot transmit HIV. And so this ushered in the era of HIV treatment as prevention, meaning that if we can get people into care, keep them in care, keep them adherent to their medications, then not only does this benefit their own health in that they can live, in many cases, normal lifespans and healthy lives, but it also virtually eliminates transmission to other people. But adherence and retention and care are critical to the success of this strategy. Next slide, please. So in terms of opportunities for behavioral health to help optimize HIV prevention, clearly the biomedical interventions, which are very effective, behavioral focus is required for proper uptake of the current prevention strategies. So it's well and good that we have PrEP, but people have to adhere to it properly. They also have to be motivated to use it. So behavioral health can inform how people are educated about PrEP, the skills they need to use in order to use it properly, to cultivate attitudes that encourage proper use of PrEP, as well as interventions to help motivate people. And this falls clearly under the purview of behavioral health specialists. It's very important. Behavior is key to adherence to the prevention protocols. And if you go back and read the original studies on PrEP, you'll see that in those studies, PrEP was successful for those who were adherent to it. And that was highlighted in the studies, although sometimes gets forgotten because what we think about is the pill to prevent HIV. We don't necessarily think about the behavioral mechanics that need to underlie that pill in order for it to work. And then in terms of treatment as prevention strategy, The only way that's going to work is if people are retained in care, and there's a big behavioral component of sustaining ongoing participation in HIV care. Next slide, please. So that's the prevention side. Now what I'd like to focus on is HIV care. So this is care for people who are living with HIV. We can go to this next slide. So in 2010, the US developed its first strategy, even though it was 30 years into the HIV epidemic at that point. The first strategy to address the HIV epidemic in the United States was established in 2010. It was updated in 2015. And one of the benchmarks for how successful we were being in implementing the strategy is something called the HIV care continuum. And what this looks at is how many people are living with HIV in the US, and right now it's about 1.2 million. Of those people, how many are diagnosed, meaning how many know that they have HIV? Of those, how many have actually been linked to and received care? And of those, how many have been retained in care? And of those retained in care, how many have achieved viral suppression? So you see this graph here, and it's from the CDC, so these are national data. The care continuum is applied at local levels as well. So many cities have adopted the care continuum model to their own local jurisdictions, but what I'm showing you here is national data, which essentially says that of all the people living with HIV, and this was as of 2015, 86% have been diagnosed, which means there's 14% that don't know about their HIV infection. 63% have received some sort of care. They've been linked to care. So they've been touched by a physician or an HIV care provider. And then only 49% have actually been retained in care, which is defined in terms of a certain number of visits for HIV over a 2-year period. And only 51% have achieved viral suppression. So if you think about the treatment as prevention model, it hinges on people being virally suppressed. That's how it works. And what our care continuum is telling us is that 49% of people living with HIV are not virally suppressed. So we've got a lot of work to do. So next slide, please. So the first step is getting people diagnosed, and that happens through HIV testing. And there are many different ways of testing for HIV. The most common is antibody testing, and it's typically done in a what's called rapid HIV testing, where you can get your results in a matter of minutes. And there are now home HIV tests where you can test for it in saliva, but also with a pinprick for a blood test. And so HIV testing has been streamlined dramatically over the course of the history of the epidemic. And the question is, what do we as behavioral health specialists bring to the table in terms of HIV testing in the current era? Well, there are several things. One is that testing informs the counseling process, both for those testing negative and positive. That for people who do test positive, we need to talk to them about what it means, and behavioral health principles can be important in terms of developing guidelines for how to talk about what it means to be positive, as well as what it means to test negative, because a negative test doesn't mean you just go off into the world, but you may need to get retested. You want to talk about ways to keep from becoming HIV infected, provide education on those sorts of things. Managing distress associated with receiving a positive test result when that occurs is very important. Helping to promote positive coping behavior, address experiences of stigma, and support follow-through with linkage to ongoing HIV care, which sets the person on the road to staying in care and becoming virally suppressed. Next slide, please. So this slide's a very busy slide, but the main takeaway here is that behavioral health comorbidities are very high in people with HIV. There's a high prevalence of psychological disorders. National studies have suggested about 50%, with depression occurring at 5 times and generalized anxiety disorder occurring almost 8 times greater than in the general population. And this is also replicated in more local primary care settings. And then there was a study that was reported at the last International AIDS Conference in 2018 that matched people who were HIV positive with those who were not HIV positive. And they showed higher prevalence of depressive and anxiety symptoms regardless of whether or not they were on ART or even virally suppressed, which is pretty impressive finding. In addition, there's high prevalence of people receiving mental health care who have a positive HIV diagnosis. And the study I cite here shows a prevalence at 4 times that of the general population, but many studies show much higher prevalence rates in mental health populations. So there's a lot of mental health treatment that occurs with people living with HIV. They need a lot of mental health support, many of them. Next slide, please. So what do mental health complications, what are their implications for HIV treatment? They decrease treatment access and retention, they compromise adherence, and they contribute to HIV disease progression and worsened health outcomes. Next slide. So one example of this was a study that was published in 2015 that looks at adherence and looks at psychological or psychosocial factors as well as certain diagnoses. So there are indicators there on the left, and some of them are psychosocial factors like history of childhood abuse, current violence, and then some are diagnoses, mental health diagnoses. And so if you have 1 or 2 of these, your odds of ART non-adherence is 4.1 times that of people who don't have any of these. If you have 3 or 4, it goes up to 5 times, and then greater than 5, 8.5 times. So this gives you a really clear illustration of the critical involvement of behavioral health, clinically significant behavioral health problems with adherence to antiretrovirals to treat HIV. Next slide. So clearly their clinical roles for behavioral health are numerous. Behavioral health specialists can help address cognitive and emotional impact of HIV and living with HIV, promote health beliefs and health behavior that contribute to sustained retention in HIV primary care, apply behavioral strategies that support ART adherence, and provide clinical assessment and intervention to address co-occurring psychological disorders, which, as a previous slide showed, is very highly prevalent in HIV populations. So our psychotherapies are very important. Next slide. Also important is the role of trauma-informed care. Trauma exposure there's a high prevalence in people living with HIV. There are some large studies that suggest that roughly half of people living with HIV have had a history of childhood physical or sexual abuse, which is 1.5 to 2 times that of the general population. Trauma exposure is associated with increased risk of HIV infection through risk behaviors, and exposure to trauma is associated with compromised ART adherence, HIV disease progression, and all-cause HIV-related mortality. So trauma-informed care focuses on understanding these high trauma rates, recognizing their impact, and creating clinical settings that respond appropriately by creating an environment that promotes a sense of social and emotional safety. Next slide. So one thing that's clear from Dr. Ulibarri's slides was that cultural factors are extremely important in thinking about working with people living with HIV, as they are with any population, but particularly with HIV, given um, the health disparities associated with it. And so a cultural intersectionality perspective is critical. And basically what a cultural intersectionality perspective does is it orients us to understanding the person in the context of various social, cultural factors that intersect to influence that particular person's experience of themselves, the world, and their HIV. And so you see things like sexual orientation, their spiritual and religious background, their age, their experiences of stigma and social exclusion, gender factors, race and ethnicities. All of these things need to be understood in terms of how they uniquely express themselves in the person of the individual living with HIV. Next slide. So because of all of these things, HIV treatment centers have really been pioneers in the whole concept of behavioral health integration with primary care. Advantages include facilitation of holistic care, expediting care coordination, enhancing service access, increasing timeliness of behavioral health intervention, and normalizing behavioral health. So rather than sending someone off to a behavioral health clinic, if they can be treated in the HIV clinic, it creates all of these advantages. So on the right, I have sort of an upside down pyramid that shows different levels of integration of behavioral health. So one is just independent, where you have your HIV clinic over here, and across town the person goes to their behavioral health provider. At the next level, maybe there's some coordination between the behavioral health provider and the clinic where the patient gets their HIV care. And then the next level of integration is where the behavioral health services are provided on site in the HIV clinic. And then the next step is transdisciplinary care team, where behavioral health providers are on the same team with the primary care providers, the social workers, et cetera. And then point of care integration, where in a single visit, a client might see their behavioral health provider alongside their primary care provider, alongside with their case manager, et cetera. Next slide. So that hopefully with a behavioral health influence, we can humanize and contextualize overall HIV care so that we're culturally responsive. We have a whole person orientation. We cultivate patient-centered relationships, and the ultimate outcome is enhanced retention and care and positive health outcomes. Next slide, please. So just in the last couple of months, the Department of Health and Human Services has announced a new federal strategic initiative to end the HIV epidemic in the United States by 2030. It's a 10-year strategic initiative that focuses on early identification of new HIV infections, rapid intervention to treat HIV and facilitate viral suppression, prevention of new infections amongst persons at risk for HIV, including a heavy reliance on PrEP, and rapid detection and response to clusters of new HIV infections. So remember, we learned earlier in the webinar that the HIV is concentrated in certain regions, and even down to certain counties in the United States. So the Southeast region is a region where it is more of an epidemic. So the idea is to focus where HIV hotspots are, with the ultimate aim of 75% reduction in new HIV infections in 5 years and at least 90% in 10 years. It turns out that recent research shows that about 40% of people living with HIV who don't know they have it or are not in care account for 80% of new infections. So this initiative is going to focus resources on those people. Next slide. So in summary, hopefully I've conveyed the multiple really endless opportunities for behavioral health to contribute to HIV care. In clinical service, we can provide assessment and intervention to treat psychological disorders, promote healthy adaptive behavior, facilitate emotional well-being. We can be consultants to medical teams. We, as administrators, we can help design patient-centered practice models and develop behavioral health integration frameworks and elaborate policies that support diversity and inclusion. And we can evaluate behavioral health processes, outcomes, evaluate integrated programs as a whole, and conduct research to advance the evidence base that helps to contribute to the success of treatment as prevention models. And with that, I conclude. Send it back to Cherie.
Okay, thank you, Dr. Farber, for that enlightening presentation. So at this point, what we want to do is take the time to have our presenters answer any questions as time allows. And Patty, do we have any questions from the audience?
We do. Yes, Cherie. The first ones, we do have a couple questions that you already did respond to, but people were probably still getting on the webinar. We unfortunately will not be able to offer CEs for this webinar, but the slides will be available on our website probably in a few days. They're not up there right now, but they'll be up in a few days. And Cherie, if you can change to the next slide, that will show the URL to go to. The next question, this one would be for Monica. What does the research say may be the cause of higher concentrations where HIV and AIDS are found, such as Florida?
So that is the research there is showing, I'm not going to talk about Florida specifically, but the disproportionate, the areas that you're seeing disproportionate rates of HIV, like in the southern US, for example, is touching to barriers such as inadequate access to health treatment, testing and treatment. So people not having the resources to access treatment and care, and also just in general low resources in the rural areas to providing the treatment and the care in the first place, and testing. There's also, and kind of, I talked a little bit about it and Dr. Farber talked a little bit about it, sometimes there are cultural and regional issues that contribute to lack of going in for testing. So that might be where stigma, for example. The other piece is, or even stigma not only for, it can be across gender, it could be across ethnicity. The other piece is sometimes these are also areas in which there are comorbid epidemics. So one of the things we also see is in areas that are disproportionately affected by the opioid epidemic, for example, that can increase HIV because people who are affected by the opioid crisis may transition into injection drug use. And also there may be, for example, comorbid hepatitis. And if HIV is introduced into these communities, it can spread very quickly. That's kind of what I kind of can think of off the top of my head. I don't know if Dr. Farber wants to add anything I may have missed, or if that covers it.
I mean, one thing that I would just add, I mean, that was pretty comprehensive, is that states that didn't expand Medicaid, many of which are concentrated in the southeastern United States, so that those states didn't expand Medicaid, so therefore a point of access to care is not available to them that may be available elsewhere in the country.
Great, thank you for all of those wonderful points. Next question. Okay, this one may help with some myth busting. Has anyone researched why gay males have higher rates of HIV and AIDS? through my observation, there is a hypersexual culture that may have been conditioned.
That is an interesting question. I wouldn't want to that. I mean, just in how they mentioned first hypersexuality, I wouldn't want to go in that direction, or I'm not necessarily aware. Haven't read anything in the literature about that. Historically, I think you need to look at historically where did the epidemic first occur in the United States, and that probably is more indicative of why you see the rates of male-to-male contact being higher as the main mode of transmission of HIV in the U.S. And so you're still seeing echoes and remnants of that epidemic in the United States, but also biologically speaking, male to male sex is also easier to, or maybe easier is not the right word, but biologically speaking, anal sex is riskier for having blood to blood contact, which can facilitate HIV infection. So that I would say is more why you will see it among MSM versus other populations. But likewise, that's why next, I think you see for women, for example, heterosexual contact is the highest rates of transmission modality, because next, biologically speaking, riskiest way of transmitting HIV would be through vaginal contact, which can include semen and blood. Dr. Farber, do you want to add in? Did I miss other pieces?
Well, yeah, I would just add, I agree that the male-to-male contact is the most efficient way to transmit. But your point about in the U.S., sort of where did HIV first start injecting itself? That's a very important point, because actually worldwide, male-to-male contact is not the main transmission mode for HIV. And it's important to recognize that. So it's not just about a hypersexual culture, and I think that's important an important point to make, in order to make clear that we don't want to stereotype that a certain group, because of their behavior, that this arose in that particular group.
Thank you. That was some good myth busting from both of you. The next question, what age group are these interventions targeting? I'm not sure which interventions they were referring to, but.
So I can start. So the interventions, I don't know if they're talking about prevention interventions or the treatment interventions, but they're targeting all groups, but they're, as Dr. Ulibarri illustrated with her epidemiology slides, there are certain age groups and that are particularly at risk in terms of there's increasing numbers of new infections. So some of the newer interventions like PrEP, they're targeting those age groups. So young adults, which are accounting for more of the new infections. And then I mentioned the concept of HIV hotspots. There are actually new data looking at down to specific zip codes in urban areas, and so there may be efforts to promote HIV prevention messages in those zip codes, because they're known to be HIV hotspots. So hopefully that answers the question.
I'd like to just add to that. I'm not sure exactly, but taking from the question, if anyone is interested, there's interventions for adults, there's interventions targeting adolescents and teens, there's interventions that are cultural specific. And if I would suggest, if people want to look there, the Centers for Disease Control and Prevention do have a list of effective behavioral interventions for HIV. So if you Google Centers for Disease Control and Effective Behavioral Interventions for HIV, you'll see that list. And there, the list shows by type, whether is it HIV testing, is it HIV behavioral risk and prevention, and that you can look it up by adults versus teens and different cultural groups, men, women, etc.
Thank you, Dr. Ulibarri and Dr. Farber. Unfortunately, we cannot take any more questions at this time, but please feel free to reach out. The contact information of our presenters are listed on the slide, as well as the APA Health Disparities Office. We also want to acknowledge hiv.gov for listing this webinar. Again, the slides will be available on our website. Finally, we really would appreciate it if you could take a moment to complete a brief pop-up survey. And again, thank you everyone for your participation, our presenters, and this concludes today's webinar. Thank you.